Bismillah ar-Rahman ar-Rahim. Good evening, everybody. I am Dr. Ali Mehsen, the medical manager of Asino Pharmaceutical Company. I'm glad to welcome all of you in this scientific webinar about practical pediatric orthopedic problems. It is organized by the Iraqi Orthopedic Association in cooperation with Asino Company. Many thanks for your attendance, for you, our attendees, and for our distinguished speakers for their valuable contribution. Now it's my pleasure to introduce Dr. Muhammad Ali Al-Bayati, consultant orthopedic surgeon, and he is the president of the Iraqi Orthopedic Association, to start the scientific session. Dr. Muhammad, the mic is yours, please.
Thank you, Dr. Ali. Thank you very much. Good evening, everybody, and good afternoon, people who are in the States. On behalf of the Iraqi Orthopedic Association, I'd like to welcome you all in this webinar for today and tomorrow. And special thanks for your efforts to support us and the Iraqi doctors on this orthopedic information. Special thanks to our branch, Dr. Mubdar Al-Qaisi in Basra, who did a lot of effort to organize this meeting. This afternoon, we are going to have 5 speakers. Dr. Scott Hovinger, clinical professor of orthopedic surgery from Stanford University School in California. And then we have Professor Tamer Hamdan. He is well known. He is the past president of University of Basra and Dean of the College of Medicine. And he is visiting professor to the Imperial College in London and a research fellow to St. George Hospital in London as well. We have Dr. Isam Hussein Ali, the consultant orthopedic surgeon who devoted his life to foot surgery from Al-Wasiti Teaching Hospital in Baghdad. He's going to speak about painful heel. And then we have Dr. Ali Ahmed, he's from our young generation, uprising orthopedic surgeon, is going to speak about DDH. And then we have Dr. Burair, another uprising young surgeon from Karbala, Holy Karbala. Is going to speak about the screening program of DDH. Now we shall start with Dr. Scott Hovinger. The mic is for you, please. Go ahead.
All right. Let me start with this. Can you see my slides? Is that working?
Yes.
Okay, very good. Well, thank you, everyone. It's a real pleasure to be part of this. I can see how many people are participating already, and so I'll try to stay with my 15 minutes, but get right into this. So just by way of me, I was born in New York, spent most of my career in San Francisco, trying to move to Colorado because it's very pretty. On the way, I made 4 children. And I've been spending the last year in London studying at the London School of Economics, so that I can find better ways to be of assistance to colleagues throughout Iraq. And I'm looking forward to my next trip back to Basra and Baghdad, hopefully in the next month. So my job is talking about late diagnosis and management, and really this happens all over the world. I've been impressed to see how mothers and fathers are the same throughout the world, that they're all impatient, they all want answers, and they want it right now. The Iraqi families tend to see multiple doctors, I've seen, and there's an issue of trust, despite how hardworking I find the orthopedic surgeons and the physicians. So that also leads to a problem with follow-through and can lead to some late diagnoses. Because the reason for late diagnosis is going to fall into one of 2 categories. It's either because the doctor didn't recognize or didn't understand the condition, or on the family side, it was far to travel. They worried about payment, or they were afraid of the surgery or what you might recommend. As I think other people are going to talk about tonight, we're looking forward to a better system of primary care throughout Iraq so people can get primary care information and not always have to go to the specialist, which sometimes causes delays. Some of the problems are going to be obvious. I mean, no one's going to miss the fact that your baby has 6 toes, or 6 feet, or that you have club feet. They may not present for treatment, but some of these problems are going to be obvious and people will know them. Others are less obvious. You can see this case of coxavera, which won't be diagnosed until the child starts to waddle when they walk, or anterolateral bowing, the possibility of neurofibromatosis, or hip dislocation, which you see far too many of, late hip dislocations. So the problems I was going to talk about are going to be late DDH, although I'm not going to spend much time on that because you've got at least 2 other speakers this evening who are going to give some talks on that. Club feet, late hip deformity from sepsis, and then some post-trauma reconstruction. I think we're all going to agree that we have to diagnose hip dysplasia earlier. It can be diagnosed in the first month. It's usually present at birth. We know the family history, left-sided, firstborn girls, but there are just far too many children across Iraq that you're all seeing at age 2, 3, and 4 with dislocated hips. So a system of primary care, maybe through the nurses, or even routine ultrasound, but somehow we have to really tackle this problem. These are the signs that we're looking for. Again, I'm not going to spend too much time on this. We can teach primary care about equal hip abduction, femoral segment lengths, or then the Barlow and Ortolani maneuvers. These are simple things so that we can diagnose this much earlier and prevent seeing the child when they're already walking. Ultrasounds, I'm not sure how common this is currently throughout Iraq, but just an example of an ultrasound. So you always look at an ultrasound as if it is the left hip looking at you. So here's the ilium, here's the acetabular roof. And so you want to see a roof that's flat so that the femoral head with the dots can sit underneath that. It won't sit all the way underneath that, but you'd like it to be seated underneath that. So if you look at this picture, you can see that that angle is flatter. This measures about 42, and this angle is going to be that 58. So you want this roof to be flatter to allow the femoral head to sit deeper. And you can also move the hip on ultrasound and watch the hip if it dislocates. When you get your x-rays, you're going to want to make sure that you've got something in the lower inner quadrant here, the inner part of the acetabulum here, and that's going to be important. If not, and again, you're all well familiar with that. When they get to be over 6 months, under 18, closed or open reduction, and I'm just going to implore that you want to get these perfect. It's hard to go back in, halfway treated hips, hips that weren't all the way in, partially subluxated, really make things more difficult. So if you treat them with a closed reduction for 3 months in a spica cast, if you need to change it more often, change it. I take kids back to the operating room whenever I think the x-ray doesn't look quite right. And then over 18 months to 2 years, usually you're going to be doing an open reduction. Open the capsule, femoral shortening if need be, and again, try to make this your only operation. You don't want to have to go back. You're going through scar tissue, so do what you can. Here's an example, the other one didn't come up, of a hip that was dislocated, and my first picture there didn't come up, that I had my hip on my post-op x-ray was sitting, it was high, it was pointing up here. So I went back to the operating room, manipulated the hip, and put the cast back on. So if you don't think it looks right, do something about it. What about when they get much older than that? And this is a real dilemma. For bilateral dislocations, most of us in the US will leave a child alone with bilateral hips over a given age. We won't agree what age that is. But bilateral hips over 8, we will not generally operate on. Bilateral dislocations over age 6, most would leave alone. The reason is you don't want to have one hip in, one hip out. That's worse than leaving it alone. Parents don't like this answer. They absolutely reject this answer. But you have to be the one to convince them or tell them that what's facing them with an asymmetric result is worse than what they have now. This is a 7-year-old girl that I saw. I saw her 2 years before, and they thought about it for 2 years and then came back. So I operated on her, and I did everything. I put her in traction. I did a femoral shortening. There was a time during the procedure where I wasn't sure I could get this hip in. But fortunately, I got in, and here's her 11-year follow-up. They do not all look like this. I can promise you that. But this is a very good result that I was able to get. Club feet. We all see lots of club feet. Fortunately, we've had a big change now with the Ponseti or Iowa method. And really, those results are simply better. I mean, I'm old enough to have done a lot of subtalar releases. We did 30 or 40, which is nothing for your numbers, but 30 or 40 in 1 year. But over time, those results are not as good as the Ponseti method. We know the deformity, but again, I want to point something out here. The ankle's in equinus, the hindfoot's in varus, the midfoot's adducted, and the forefoot is pronated. And this is key because the first maneuver is to try to correct that pronation. And the results from the IO on the Ponseti method are now worldwide, and I know you do them, and they require patience, and the results are quite good. If you ever have an opportunity to take a course from Matt Dobbs, who is pretty much the world expert in this now, he's a very practical guy, and he'll tell you, there's no magic to this. It's just knowing how to do the casting. And the first maneuver with the casting is to supinate the forefoot. The first thing you want to do is supinate the forefoot to match the hindfoot, and then put your thumb just anterior to the lateral malleolus and bring the foot around. So your first maneuver is to supinate, and then gradually take your time. Take time doing this. Have patience with this. Think of the concept of the acetabulum pedis, which is the navicular, the cuboid, and the calcaneus forming a socket around the talar head. And your cast should look gradually like this. This is 5 casts. If it takes 6 casts, if it takes 7 casts, take your time. Don't use short leg casts in young children. It's simply not going to work. Just don't do it. Once the foot's abducted, then you can release the Achilles. You can do it in the office. You can do it in the operating room. You can do it open if you wish. Whatever you feel most comfortable with, but cut the Achilles completely. It will grow back. Parents don't believe it. It will grow back. We know that. Then you use the shoes in a bar, and you have to remind them constantly. Every week you talk about this treatment. If you stick to this like a recipe, the result will be good. Older children, I've watched Matt Dobbs do this on kids that are 9, 10, 12 years old, and I can't get those results, but I always begin with casting. If you begin with casting, and in the older kids, you can use a short leg cast so they can walk, and start with the same treatment, start with supination, abduction, you will at least need less surgery, and therefore you'll have less scarring and less stiffness. Septic hip deformity, I want to talk some about this because we all have these, and my advice on a post-infected hip deformity is don't try to be a hero. Don't go into the hip joint. There's only so much improvement you're going to be able to get. So here's 3 cases we're going to take a look at: a septic dislocation, septic deformity, and then sepsis with some degenerative disease and a short femoral neck. You don't want to get into multiple surgeries. You don't want to get into repeated operations. They generally have joint stiffness, but more than that, the lower extremity is in a bad position. That's what you can improve. And you can't make this all better. The capital physis is only 8% of the length of the leg, so why does it seem so short? It's because it's in a bad position. You don't need much hip motion. You don't need abduction. You don't need rotation. You only need some flexion. But the problem is the bad position. So here's this 12-year-old boy, and the measurement's a little bit short, but what makes it worse is how adducted that leg is. That's what makes this thing appear even shorter. When I try to abduct his leg, his pelvis moves. When I abduct it, look how much motion that is. It's easier for him to move his lumbar spine than to move his hip joint. So unfortunately, this doesn't come out. What I'm trying to show is that when the short leg, that hip has to abduct when you dip down. If it doesn't and it's stuck, then that leg goes across. So the result is the leg seems much shorter. And so when you compare leg length inequality with hip motion to leg length inequality with bad hip motion, the difference is much more pelvic obliquity if the hip doesn't move. So all you can do, and you successfully can do this, is improve the position of that hip, not the range of motion. So for this boy, we saw how much he adducted and abducted, and I recreated this by taking a wedge out. And now, rather than standing with the hip adducted, he stands with his femur perpendicular to his pelvis. This boy saw at 18 months, we watched his hip grow with deformity. We watched him grow into adduction. He limped. We kept telling the parents to have patience and wait. Then eventually I did an arthrogram just to make sure his hip would not slip out of the acetabulum. But most importantly, once he was adducted enough, we did a valgus abduction osteotomy at around age 4. And I think this is about 4 years later, 4.5 years, he still has a good result with his femur perpendicular to his pelvis. Don't go into the joint, just take what you've got and restore the position of the femur. This girl had multiple areas of sepsis and growth plate involvement, but look what happens as she grows to that hip. Look how adducted she is. Look at that pelvic obliquity. And so what we did with her is as she got older, we had to straighten this out, but we did a valgus abduction osteotomy. And now look how she stands. Look how perpendicular her legs are to her pelvis. Last thing, I want to talk a little bit about elbow trauma and delayed trauma malunions. They happen from montasia, from supracondylars, but cubitus varus happens so commonly from untreated supracondylar fractures or even pinned ones that lose position. And what we want to know is we want to understand the deformity. We want to understand all 3 planes. There's internal rotation, there's varus, and there may be flexion or extension. I want to wait till they're a year out. I want to know that they understand that this isn't a cosmetic operation. I'll still do it, but I want them to know the goal is to make it look good. An important point is that since your fracture is here and your osteotomy is here, you have to translate or you're going to leave a bump. So if you just cut the wedge out, you leave a bump, so you have to slide it. And that's important because you're trying to make this look better. You can measure this many ways. These measurements are not very reproducible, so I measure lots of different ways of the right and left side so I know the angle. The results that are published in the literature show some very poor results, loss of correction, unsatisfactory results. So be careful with these. Whatever method you choose, understand the deformity. And one point I want to point out here is this is what your eye sees. This is a CT scan through an MRI rather through the antecubital fossa. But since you're proximal with your osteotomy, this is the shape. Your eye will want to operate in that plane, but that's not it. If you operate in that plane, you're not going to be fixing the deformity down here. So you have to accept this position and then put pins across so you know exactly what plane you're operating in. Otherwise, your correction will be off axis. So you can cut it, you can slide it, you translate it a little bit before we pin it. Same thing with this girl, slid that over, and got her in better position. Last case we're going to show the boy had a lateral condyle fracture treated. He ended up with a growth arrest laterally. So we ended up with cubitus valgus. He ended up with ulnar nerve symptoms, but we waited until they were getting worse. And then 8 years later, he had enough symptoms and we went in. Again, my osteotomy is proximal, so I have to translate it. And we also transposed the ulnar nerve. This was a girl who had a little bit of deformity, only needed a little correction, so we just put a wedge and a little buttress plate on there. But again, this was a cosmetic operation, so I needed to get it cosmetically just right. So my conclusions as far as late treatment is understand the problem and set realistic goals with the family. I'll want to see people back a few times because maybe the problem is late because they didn't return. Be patient with your plan and make sure the family understands what the goals are. Thank you. Thanks for attending tonight.
Dr. Mohammed, please unmute yourself.
نجاوب. اكو مشكلة بالنت يا محمد. ما جاوب. شوف الوقت.
ست حجماتك يا سمع محترم. شغل يستوعب عادي بالمقدار.
Hello.
Yeah, I'm ready.
Yes, go ahead, please.
Yeah, okay, will do.
Please go ahead. Professor Thamer is going to speak about irritable versus septic hip.
Yeah, thank you. It's really a bigger problem, and we have to differentiate between irritable hip and septic hip. Otherwise, the outcome is a real disaster. Sometimes it's a perplexing clinical feature and one intermingled with each other. But just to remind you, irritable hip is idiopathic and aseptic synovial inflammation in the hip joint in childhood. Non-specific, short-lived normally or usually, is a benign outcome. Though it's benign, but my personal experience tells that we have to keep an eye on the patient with irritable hip, because some of them, they will change into perthes. Septic hip, of course, is...
Professor Thamer?
No.
Can we go full screen?
Yeah, it is full screen on my side.
It is not here.
Yeah, is it here now?
Better now, yes, thank you.
Okay, so septic hip, you know, it's well known to everybody. It's a bacterial infection of the synovium, and subsequently of all the structures of the hip joint will be involved. The risk is damaging the upper femoral epiphysis, which is the major contributor for the growth. Incidence-wise, irritable hip is seen normally 3 to 10 years, peak reach 5 to 6 years of age. Boys are 2 to 4 times more affected than girls, probably because they are more active than girls, probably so. And the family history is rarely elicited. Septic hip is commonly seen between 2 years of below 2 years, but it can occur at any age. And the worst is the neonatal septic hip, which is not easy to be diagnosed. And the child presents with paralysis of the limb, and he might be not showing the cardinal clinical feature of acute inflammation. So neonatal septic hip is usually, sadly, missed. The exact cause of irritable hip is unknown, probably related to GI infection, upper respiratory tract, trauma, or allergic hypersensitivity. The risk for septic hip, on the contrary, is of course, the diabetic patients, the malnourished, and so many causes. But of course, early diagnosis and appropriate treatment are the key for success and usually leads to good outcome. Now the question arises, how do we differentiate between this and that? That's what we are looking for. Pain-wise, and we see it's mild and transient, but it is very severe. The child can never put weight on that particular hip. Weight bearing, he can walk when it is transient, but can never bear weight. Constitutional symptom, the child with transient synovitis are looking well, but with septic hip, they are usually toxic child. Movement is relatively full range, relatively, not really full, but in septic hip, there is severe restriction. Progression, usually the irritable hip is a self-limited disease, but the septic hip is a progressive. Even with good treatment, it will not leave a normal hip. And they used to say that arthrotomy may induce more damage than the septic process itself. And the sequelae of irritable is good, and the sequelae of septic hip is bad. Physical examination, of course, the transient synovitis mostly normal position, while in septic hip there is a resting position of flexion, abduction, external rotation. Range of movement almost normal in transient, severely limited in septic, And local signs, swelling, warmth, erythema, and tenderness. The cardinal clinical feature of acute inflammation is absent or minor in the transient, while it is frankly present in the septic hip. Gentle technique of examination is required, and sometimes you need to repeat the examination in both conditions. Investigation, this is the cardinal, the standard investigation, which is C-reactive protein, ESR, and it is not simply one measurement of C-reactive protein, but it is the rising titer of C-reactive protein, okay, which is really very beneficial. And so it's normal. White BC and differential again is beneficial. It's normal in the transient, but it is the white BC usually high, but it's not very much dependable. So I put my money on the ESR and C-reactive protein. The ESR is normal here, it's above 40 there, and the C-reactive protein not progressive. This is very important. Not a simple reading, it's the rising titer of C-reactive protein, which is the significant ones. And this is X-ray, which sign of effusion, widening of the joint space, that the space is wider on the left side. Discrepancies greater than 2 millimeters indicates the presence of fluid. Of course, again, this fluid can be detected by the MRI and can be detected by the ultrasound. Okay, and here we are, this is the radiograph of 8-month girl with a 4-day history of fever. Painful right hip demonstrates soft tissue swelling, lateral to the hip joint, pelvic obliquity, diminished contrast between the bone and the soft tissue and right hip subluxation. So this is highly suggestive of septic hip. Ultrasound is very useful, and our dear colleague Scott tackled these points, and it's non-invasive procedure, but it needs a good experience. Not everybody is capable of reading ultrasound of the hip. MRI is again very beneficial, and you see a signal intensity alteration of the bone marrow and the soft tissue. So you have to concentrate on the bone marrow. Once the bone marrow is abnormal, this indicates that there is something wrong. And there is significant decreased perfusion at the femoral epiphysis in patients with septic hip. Unfortunately, MRI is not a routine diagnostic tool and less accessible than other images modality, probably because of economic, because of finance, or unavailability of the MRI in some countries. Joint fluid aspiration ultrasound or fluoroscopy guided, becomes mandatory as soon as the clinical variables point to septic arthritis, if the situation is unclear. But of course, better to avoid putting needle when the clinical feature is suggestive of irritable hip, because you may change the irritable hip into septic hip. When no fluid obtained, 3 to 5 millimeters of sterile saline are injected and they're re-aspirated, because sometimes there is not much fluid. A result confirmative of septic arthritis, purulent appearance, low glucose in the fluid, high protein, more than 50,000 white BC cell count per cube per millimeter, with predominance of polymorph for a nuclear leukocyte, more than 75%, and positive culture or positive gram stain. So this is, of course, definitely indicate that it is a septic hip. Masking factor in the diagnosis. On the top of the list is the neonate. And that's what you call a pseudoparalysis. And obvious because the immunity in the neonate is not yet mature. In the first 6 months of life, the neonate is depending on the mom immunity. So the acute inflammatory response is not clear. That's why it's missed. and early presentation less than 5 days, trauma, other illness, sickle cell disease, of course, in our locality is a big headache and bigger problem, and it, of course, support the diagnosis of septic arthritis. And then, of course, we need, the problem in our locality is steroid and antibiotics. It is given not in the proper way, and both mask the cardinal clinical feature of infection. And that's why a lot of septic hip present late to our clinic. Either they give the antibiotic below the required dose, so it's a half, I would say a halfway treatment. And of course, corticosteroid would abolish everything, like giving pethidine to acute abdomen. And then, of course, on the top of everything is a special care for the immune-compromised patients. Clinical predictor for the differentiation are a high temperature above 38.5, not capable of putting weight under any condition, or some of them never allow you to touch his limb. And if you do internal or external rotation of the hip, it's very painful, and he is resisting to this. ESR above 40, white BC high, and C-reactive protein. All these 5 would help in the differentiation. The 4 parameters can be used to predict the likelihood of septic arthritis is pyrexia, elevated ESR, increased white BC, inability to be weight. And then this is the number of the parameter which is positive, and then the probability. You can put this with this, and you end up with active. Physician practical knowledge and experience are needed in the unclear situation. And as everybody knows, there is no substitute for the experience. It comes on the top of everything. The most recent study was performed by Sinhal et al. In 2010, and C-reactive protein with a rising titer again is strong and the most significant independent predictor of septic arthritis, including C-reactive protein with weight-bearing status eliminate the significance of other variables. And here it is, it's a feature suggestive of septic hip. We go for investigation first, and then aspiration, and then we start empirical antibiotic, and if no response, then repeat aspiration or erythrotomy. Try your best to give the proper antibiotic, which is a broad spectrum, and usually anti-staph, and try your best to avoid doing erythrotomy as much as possible, but sometimes it is obligatory. You have to do it under any condition. Transient synovitis, usually marked improvement within 24 to 48 hours. We put them on skin traction just to keep them in bed and to oblige them to stay at rest. 2/3 to 3/4 of patients have complete resolution within 2 weeks. But as I said in the beginning, still they should come for re-examination every 3 or 6 months. The reminder may have less severe symptom for several weeks. Recurrence rate is 4 to 17%. Most recurrence develop within 6 months. So it may reappear again. That's why I said you have to keep an eye on them. But to be honest with you, I've noticed some of them on the long run turn out to be a case of tuberculosis of the hip. And it was in the very initial stages, or it was a case of Perthes disease on the long run. This is my personal view. Complications of transient hip, Coxa-Vara, Coxa-Magna, and Perthes disease. That's what we have seen, but this is rare. And then damage to the growth plate with discrepancy of leg. This is very bad, and I've seen it. That's for the septic hip. Septicemia, osteonecrosis, complete loss of the femoral head. I've seen that, and neck, stiffness, hip dislocation, and on the long run, they got into a stage of early osteoarthritis. Take-home message. Differentiation between transient synovitis and septic arthritis is crucial and should be done as early and as soon as possible. There are 5 important clinical and laboratory variables that greatly help in the differentiation, and this includes temperature above 38.5 and non-weight bearing ESR high, white BC high, and as I said, a rising titer of C-reactive protein. Physician knowledge and experience can ensure an excellent diagnostic performance in the differentiation. Better to give detailed information to the parents about the outcome of septic hip, because everybody knows it's not easy to have a normal hip after septic hip. And thank you very much.
Thank you very much, Professor Thamer. And our next speaker is Dr. Assam, who is going to present painful disease. Dr. Assam, the mic is yours.
Yes, thank you very much. Today I'm going to present a short history of a case. He's a boy of 12 years old complaining of pain in the left heel. The pain started after a trivial mild trauma before 1.5 years. He had been treated as a severe disease, but without improvement. The pain is moderate in nature. He can walk heel off weight. He sleeps well at night. He is good, healthy, without past medical history. And in his left limb is nothing significant, no lymph node enlargement. Next, please. Next, please. Well, the left heel is slightly swollen in the sole of the heel, not red, tender, not hot. For range of movement of all the joints of the ankle and the foot. Next, please. This is a picture of about 2 weeks ago from the medial side of the left heel, and we see the heel, and these are 2 scars, the scar in the heel and the scar in the anterior to the medial malleolus. Okay, next. We compare the 2 heels, the right, the left above and the right below. Next, please. Next. During this 1.5 years, I told you, is treated as a severe disease, and several investigation and X-ray and CT scan and MRI done for him. This is the X-ray, and it is not a conclusive, but there is mild fragmentation in the epiphysis of the calcaneum. Next. Next, please. This is the X-ray to compare the front between the right and the left. Next, please. This is a picture of the CT scan, which is not conclusive, and we will see the report of the CT. The patient did several times a complete blood test and picture, and all the investigations were within normal. Next, please. This is the lab investigation. The ESML C-reactive protein normal. Next. Next, please. This is also hemoglobin, PCV, C-reactive protein, ESR, all within normal. Even blood sugar and serum uric acid also done for him. Next, please. This is the report for the CT scan, which is not conclusive, and he suggests that it is a severe disease. Next, please. This is the report of an MRI, which is nothing significant, only a minimal talocalcaneal joint effusion seen. Next, please. Before about 1 year ago, he did a synovial biopsy from the sinister side, and the result was not conclusive at that time. When I saw him, I put him on under cover of antibiotic for 2 weeks, and with analgesia, heel pad, and non-weight bearing and rest. But after that, the pain is recur without any improvement. Next, please. This is the result of synovial biopsy. It seems to be everything is normal. Next. About 4 months ago, I consult my colleague in Al-Wasiti Hospital to discuss the case. So we agreed about to do an exploration from the medial side of the heel. So I did an exploration, hoping that I will find some soft tissue tumor or something else, or hidden infection with that we can't see it. But unfortunately, nothing. I took a biopsy from the plantar fascia, part of the plantar fascia, part of the soft tissue beneath it, and the biopsy shows a benign fibrofatty mass. Next, please. This is the biopsy done 4 months ago, but the patient is still having pain in spite of analgesia, heel off pad. So I asked for the help to see what to do next step, and as a part of treatment for this boy. Thank you very much. Next. Thank you.
Thank you very much, Dr.
Are you finished, Isam?
Okay.
Isam, you finished? Dr. Isam, you finished?
Can you hear me?
Okay, yes, I can hear you. Dr.
Good
Ali.
afternoon. Good
Welcome, Dr.
afternoon,
Ali.
everybody.
Welcome.
I am going to speak few points about the delayed diagnosis of patient with DDH in our locality in Basra, Iraq, and who's responsible for this delay, and whether we can be better or not. Everybody knows that DDH is developmental dysplasia of the hip joint. So developmental mean that normal hip examination for a neonate does not exclude hip dislocation or DDH, because it might appear later on. Regarding the incidence of DDH in our locality, I am going to speak about my personal data. So in Basra, we see around 7 cases a week. So 7 multiplied by 52 weeks. So it's about 364 cases a year. So how these cases presented to us? Just 2% presented as a neonate. And how this neonate presented to us? Just 1% by a screening test. And another 1% presented as a septic hip. What I mean that it is referred to us when the physician or the pediatrician diagnose it because it is a tender hip, not because of a screening for DDH. And just 3% presented during infancy. How they presented to us? Either they have a previous bad experience with the family, the same family, for example, have a daughter or they have a mom with DDH, or they discover accidentally by another surgeon or physician, or they have a relative with a bad experience, or they are relative of a doctor and medical staff. 95% of our cases presented at a walking age. 65% below 4 years and 30% above 4 years, especially bilateral. So at this level, let us say that 30% of our patients beyond treatment. If you compare our data with those from United States, I get it from my friends there. 97% of their patients diagnosed at a neonatal age, either because of hip ultrasound or because of a screening test. And only 3% late diagnosed, either because they are new immigrant to the States or maybe because of family with bad compliance. Why this neglection in Iraq? And who is responsible for this neglection? It is multifactorial. It is the responsibility of the government and the doctors, and also families never. Because of any educational programs or social media or any TV or program that advise for the DDH screening or something like that. Either because of lack of awareness. So if you are not aware about DDH, you're not going to screen about that. Or maybe because of neglection, it is a careless disease. Or maybe because of no experience. So if you are aware about the disease, you have to be expert also to screen about that. What about the family? Either because of bad habits, or maybe so because of the poor compliance of the family, especially those with public harness compliance. Diagnosis of DDH. What is the best diagnostic tool a neonate? Screening test for a hip? Yes. Orthilani and Barlow test is a very good screening test, but negative test in a neonate does not exclude DDH. So, what about the X-ray? Normal X-ray does not exclude a DDH in a neonate also. So the best investigation or the best screening is ultrasound, which unfortunately we have a limited number of pediatric hip ultrasonography. I don't know why. Maybe because of the financial problems. Treatment of DDH depends on the age of the child. For a neonate, the public harness is the best treatment with a 99% success rate. For the infancy, a doctor tenotomy with the spica with a success rate more than 80%. At walking age, most of them, they need open reduction, pelvic and femoral osteotomy, and a success rate might reach to 70 to 80%. More than 4 years, unfortunately, most of them, they not need any treatment because of high morbidity and complications. So that early diagnosis, less invasive, better results. Late diagnosis, more invasive, worse outcome, and legal action. So take home message, always keep DDH in your mind. Do screening for every neonate. Make hip examination as a routine for every child. No rule of X-ray before 6 months. Be careful, negative exam, negative X-ray, negative family history, all does not exclude DDH. Refer a patient with DDH unless you are seeing a lot of them. Treatment of DDH, not for a weak heart. Don't be cheated by a syndromic with DDH. So always look for associated meningocele, cerebral palsy, or associated poliomyelitis, arthrogryposis, any associated anomalies like knee dislocation. So please don't focus on the hip alone. Examine the patient as a whole. Be careful of delay milestone or delay walking. I did too many cases of DDH, but unfortunately, I discovered after that they are some of them that they are a case of cerebral palsy. So always look for the milestone before treatment. Although DDH might cause delay walking, but not that to that severe extent. So always assess the milestone before starting treating the DDH. So don't treat the X-ray. Always examine the patient as a whole. Don't rush into surgery in the following patients. Number one, boy. Everybody knows that the DDH is very, very common in girls. So it's okay with boy, but always when you find a boy with DDH, look for associated disease. Patient with a previous failure. When you are facing a patient with a previous failure, don't rush for surgery. Don't rush for revision. For my experience, I always do a revision surgery after non-expert surgeon, because 70% for those who non-expert, they do or they did, halfway surgery. So I prefer to do revision after non-expert surgeon than to do a revision after expert surgeon. So it's rarely to do a revision after expert because I know that they did their best. Don't rush in surgery or be careful in our locality for a neonate that refer from another doctor. As I told you, we don't have a screening. So why they refer a neonate with DDH? So most of them, they refer because of a tender hip. So keep a septic hip in your mind. Don't rush in a surgery with a patient with other congenital anomalies. Always assess that patient, whether he will be able to walk, whether he will able to move, or he can get benefit from your surgery. Always don't rush for surgery if you have a limited experience or limited facilities. Always inform the family about the high chance for another more surgery, especially after adductor tenotomy or closed reduction. Some of your patients might need in the future duration osteotomy or additional pelvic osteotomy. Also inform the family about the risk of AVN and the risk of redislocation and the stiffness. Don't be overconfident. To be honest with you, I did some cases of open reduction bilateral at the same time. But for me, I prefer to do one at a time because it's not logic to put an extra stress over the surgeon and the patient and the anesthetist, and expose the child for a long anesthesia. So always prefer to do one side each session. If you don't do good, don't do harm. So please, before you are putting your knife for a patient with DDH, always ask yourself, are you going to help that baby? Otherwise, don't touch that child. And thank
مقدمة لا مو
Thank you, Dr. Ali, very much for your talk. Now we are going to listen to Dr. Burair from Karbala. He's going to speak about screening program in Holy Karbala city about DDH. Please, Dr. Burair, your mic is yours.
الحكي مالك نصه ما شفته.
My greetings to
Burair, you heard me?
yes sir. Okay.
Okay, go ahead.
My greetings to my mentors and my colleagues, and it is a good opportunity to meet them today, and I hope all of them are safe and well in this pandemic. I would like to stress on some points that mentioned by Dr. Ali, and I will give our experience in trial of screening program that we did, and what are the problems we face. As you know, the objective for this talk is types of screening program. I will discuss it briefly, what we do in our city, our early results, evolving practical problems, and to evaluate the applicability of DDH screening program. Again, the same question as mentioned by Dr. Ali, undetected DDH, who is responsible for that? The parents, because they don't know their child have DDH. Of course, they have no education on who told them about. The pediatrician who receiving the baby after labor, or he treat the baby after that, maybe after 2 months or 3 months. Usually they went to a pediatrician for any other cause like cough or anything. He should look for DDH or not, and is that his work or not? The family doctor or the general pediatrician practitioner in the healthcare centers, or the orthopedic surgeons, or other healthcare providers. And I mentioned especially the Ministry of Health, like in our locality. So I think all of them are responsible in that. And in that, all of them, they are matched together in a screening program. The aim of screening, as you know, is to reduce the incidence of late presenting DDH. The incidence is 1 to 1.5 per 1,000 all over the world, and different from country to country. There is an Australian HIB universal screening. It is started 30 years ago, and one study published in 2011 comparing the cost effectiveness of universal ultrasound screening compared to a clinical examination alone. And they compared two 5-year period, before screening 5 years and 5 years after screening, and they found that 76% reduction in the surgical intervention after screening program. What are the options for screening program? You know, the clinical examination is one of the options to screen the babies, but usually we cannot rely many times on it. As mentioned by Dr. Ali, we fail sometimes because either the technique or the experience of the examiner. And in subtypes also, even the experienced surgeons, when they examine the hip, there are some points that type 2C, for example, or early type D, they have no clinical signs to appear. So they will be missed that early stage of hip instability. And it is well known that in the papers that the examination sensitivity alone is only 60%. So there is about 40% will be missed by clinical examination, even in the experienced hand. Ultrasound, as mentioned by Dr. Ali, is a good and sensitive mean for examination, and it is available and cheap. And according to the ultrasound, there is either selective screening, according to the risk factors that's used in UK and USA and Australia, or universal screening, that they examine all the babies born. This seems to be theoretically more ideal, and it is used in Germany, Switzerland, Australia, and Poland. You know, the pioneer for hip screening by ultrasound is Mr. Graf. He is having the Graf method and Graf stage in DDH screening. And actually, till now, many papers speaking about the universal screening. Another paper is speaking about the selective, and which is better. I think this is left to the country and according to the facilities of that country. In our city, in Karbala, we have about 43,000 live births per year. And me and my colleague, Dr. Hussein Ali Hakim, he is a brilliant orthopedic surgeon with pediatric interest. We take on our shoulder to start this screening program in our city, hoping that we can help our children. It is a big job. It is not easy to start these projects. And we started that step by step. We started training programs for the radiologists first, because as mentioned by even Dr. Thamer said that many radiologists have no experience in that. So we brought an expert surgeon. He is doing a just hip DDH, and he is very clever and expert in DDH ultrasound. And he give them the tricks and tips to do the DDH ultrasound screening. And then those trained, after they get good training, they go to train the more junior radiologists in the healthcare centers. And then me and Dr. Hussein, we start to training program for the family doctors and for the general practitioners in the healthcare centers to educate them how to think about the DDH and how to examine for DDH, at least to promote them to do examination and to think about the condition. Then we put theoretical points regarding the screening program, and we suggest a selective screening, and we see the selective, and we also suggest the universal in some centers. And we put these points regarding the first baby, female, family history, breech presentation, oligohydramnias, twins, any congenital anomaly. We put these points on a paper sheet, and we give it to the doctor or family doctor just to put a mark on every, if he found any of these in the history, or if he found anything in the examination, as mentioned in this paper sheet also, any obvious abnormality, short leg, asymmetrical thigh folds, limited abduction. We all concentrate very much on this point, limited abduction. And of course, Barlow test and orthodontist test, they are difficult to do in a crowded condition in the healthcare centers. Then we put to them this algorithm. If they found a negative history or examination, no points in history or no points in examination suggestive of DDH. So no further management, just awareness and education for the families, because those families will also educate their friends and their other people about the DDH screening. If positive points they found in history or examination, they will do a hip ultrasound. And then accordingly, if the result of ultrasound was negative, then we repeat the ultrasound after 1 month, because sometimes the ultrasound, as you know, it is the operator dependent. It may be missing, false positive result maybe, so, or false negative result. So we repeat after 1 month. If it is, even the ultrasound was positive, and then they refer that to us in the DDH clinic in our hospital. And this is an official screening program started by our health directorate. And also we present this screening to the Ministry of Health. We're hoping that to get support at least to our program. And the screening program, we started it in 5 health centers actually. We choose the age of 2 months and 4 months because we can catch the babies at that time during vaccination, because they usually come for vaccination. And we started at 2 months. In 5 healthcare centers, and in 2 health centers, we did a universal screening. Just we want to try what are the complications or what are the problems you will face. And 3 of them, we did a selective screening program. Our results in 5 centers for 6 months follow-up, actually. 2 centers with a universal screening, they examined 811 baby, and they found 4 cases diagnosed with DDH. And 3 centers with selective screening, they examined 1,009 baby, and they found 13 cases diagnosed with DDH. And totally 1,820 examined baby, we found 17 cases of DDH. Those 17 cases, of course, referred to us, and we rescan them, of course, and because we cannot depend on one ultrasound, and we found 7 cases false positive results. Then we left with 10 cases of DDH, and it's actually about 5.5 per 1,000. And these cases ranging from a graph 2B to a graph 3. What are the problems, or let's say, what are the difficulties or obstacles we found in our screening program? I noticed 10 problems, actually, I mentioned, 2 of them from the patient side and 8 of them from our side. From the patient side, the first problem that the parents are usually uneducated about the DDH risk factors, and no early screening program exists before that. So this makes us more effort from us to convince them to participate in the screening program. And the second point is the parents' awareness of DDH during the screening was inadequate. Either underestimation of the risk or low participation of the families. Sometimes they come for the first visit, they don't come another visit. And sometimes the insistence of on making a swaddle, despite we warn them a lot. From our side, the problems or the difficulties or the obstacles, we found many. Lack or poor educational programs, deficient number of radiologists. And actually, you know, we need radiologists in the healthcare centers and we need radiologists in the hospital, and they are actually not enough. And some of them are females getting a sick leave or labor or pre-labor, and this make a disturbance in our program. Not expert radiologists in healthcare centers, and many times make overdiagnosis or undiagnosed cases, and actually we can solve some of these problems by re-examining them in our hospital with expert radiologists. Work overload on doctors, as you know, in Iraq, the family doctors and the GP doctors and even the radiologists in the healthcare centers are usually busy. Old version ultrasound machine in some centers. Operator-dependent results of ultrasound, which make more burden on us. We need to repeat that, and even the burden on the patient, because we repeat the ultrasound maybe 2 or 3 times. Lack of electronic data. Till now we are doing a paper sheets, not making electronic data. And problems in the referral mechanism, because sometimes they told the parents to go to the hospital, they don't know where to go and in which day they go, and etc. Some of these problems, we try to solve them. We provide training programs for GP and family doctors whenever they need. We make training programs for radiologists whenever they need. We bring an expert radiologist, even from outside Iraq, to train them. Free of charge clinical and radiological examination, I mean ultrasound examination in our hospital, and without previous appointment, just we want to promote them. Free of charge splints in our hospital, and also we started educational programs during the social media and newspapers and etc. So in conclusion and home message, DDH screening program will achieve early diagnosis, patient satisfaction, less cost of treatment, less complication and better compliance of patients, and it is also useful in researches and data for such major problem. It is necessary to conduct a pioneering study to determine the difficulties while planning a national screening program for any region, and the effectiveness of the effective means such as the media, governmental and non-governmental organizations should effectively use in DDH screening program. In spite of difficulties, DDH national screening program is necessary to start in Iraq to control or reduce the catastrophic complications of missed DDH in our lovely children. And final hope message, this is not from me, from Mr. Graf. He said, every child deserves to have a hip scan by ultrasound. And thank you very much.
Thank you, Dr. Burair. Thank you very much for your nice speech. And this is a hopeful, nice pilot screening program from your city in Karbala. We hope that this will be all over the country.
Thank you, sir. Thank you.
Now, you heard me, Burair? You heard me?
Yes, sir.
You can hear me? Thank you.
Yes, I'm with you.
I must thank all the speakers for their valuable talks. And I also extend it to our audience every over the world. Now we're going to start the section of questions and answers. I'm sure most of you have seen answer them by writing, but I chose 1 or 2 or more questions for every one of the speakers, so interacting Tamir suggested. The first questions are to Dr. Scott, please. Are you Dr. Scott? A colleague asked, what type of pelvic osteotomy do you prefer? Dr. Scott, can you hear me?
Yeah, what type of pelvic osteotomy do I prefer?
What type of pelvic osteotomy do you prefer?
So for me, I found that the Salter is still my best osteotomy. I've tried different types of osteotomies, but over time, I've seen as the kids got older, I know what my Salter is going to look like. First, I can do it pretty well. And when I watch the child get older and being around a while, I know what that's going to look like. My Pemberton osteotomies, I don't like how they look over time, even though Dr. Ali Aiden taught me how to do a Dega. I went home and tried that. I didn't do that very well. So you have to check yourself. And for me, I still like the Salter.
Thank you very much. The second question is, a colleague asked, what is the role that you prefer? Would you prefer orthosis or what opinion? In conjunction.
شنو ادخل عليه بال
Sorry, could you repeat that?
The role of orthosis, please. Orthosis.
So, well, the Pavlik harness for the younger child, and then if you have persistent dysplasia, we'll use an abduction brace, like an Ilfeld splint or many of the different types of abduction braces. But we don't really have any proof that those work. Once a child is walking, I don't think they do anything. But I'll use an orthosis after my spica cast, after I treat a child in a spica. I'll come out and put them in a brace. Or if I'm treating a child with a Pavlik and the hip is now located and stable, I'll use an abduction brace until they're walking in hopes that that will help the acetabular dysplasia.
Thank you very much, Dr. Scott. Thank you very much. I have a couple of questions.
Yeah. Can I enter, Dr. Muhammad? Yes, sir. You hear me? Please, Dr. Scott. You hear me, Dr. Scott?
I hear you.
Thank you. You tried triple osteotomy for a child with neglected DDH, 6-7 years of age,
Yes.
while the acetabulum is severely dysplastic.
Yes.
Is not fit for Salter or another osteotomy.
Yes. So that's a good question. So I'll use the Salter up until age 4 and 5, and over 6, I don't get as much correction. And so at that point, if I need that, I'll do the ischial cut and the pubic cut. I don't do the periacetabular osteotomy, and really at that age, I just need to get a little bit more out of it, and so I just am able to cut the pubic rami, and then the Salter is able to move the acetabulum enough. So yeah, as they get older, that's what I do. Thank you.
So it is a triple.
Yes.
I have 3 cases. They are doing very well.
Beautiful.
Thank you. Thank you, sir.
Thank you, Ali. So we move questions to Professor Thamer, please. Professor Thamer. Professor Hamdan, are you here? Professor Hamdan.
Yes, I'm ready.
Thank you. A colleague asked, how much do you depend on Kocher criteria for septic hip?
Yeah, it's useful, but as I said, this is the standard method of doing the differential diagnosis. But anyway, it's up to him. He can find the best way.
Thank you very much. The second question is, a colleague felt that you are a little bit reluctant to do arthrotomy, you prefer aspirations, and how many times you do aspiration before you embark on arthrotomy?
Yeah, you know, arthrotomy, I said it, may do damage to the joint more than the septic process. So if you can finish the story by a heavy cover of antibiotics and aspiration, you can aspirate once or twice, depends. But of course, the child should go under a light general anesthesia. And you have to identify the ideal site for aspiration after feeling the femoral artery so that you don't go inside the femoral artery. You can repeat it and you can wash the joint by normal saline if you like. I mean, you take material, you push normal saline, and then you aspirate. Needle in position,
Of course.
you can push it through it and take the fluid out.
Thank you very much, Professor Tam. Thank you very much. I have two questions to Dr. Isam Hussein. Dr. Isam, can you hear me? Isam?
I'm with you.
Yes. A colleague asked, did you recognize the site of the pain and if there is any possibility of a foreign body there? Please unmute yourself. Isam, please unmute yourself.
Okay.
Repeat your talk, please. Repeat your talk. No. Your microphone is closed. Open the mic. Isam.
Dr. Assam, can you please
We
unmute
can't
yourself?
hear you.
Unmute.
Yes.
That's it.
Unmute yourself, Isam. Now repeat your. No, you are mute. You are mute, Isam. Dr. Muhsin, can you unmute him from the? No, Isam, we cannot hear you.
لا استاذ لازم من يمه.
مش عجب بدا يعرفه.
لا مو احنا.
No. At the bottom of the screen, Isam, unmute yourself, please. Unmute yourself. Can I?
Mohammed, I think to shift to another question until the problems.
Okay. Let's talk to Dr. Ali Idan, please.
Yes, ready.
I have a question for you. What do you think about von Rosen view in diagnosis of DDH? At what age?
Von Rosen view, it's helpful in neonate, okay. But this was used before when there was no ultrasonography. Now the best diagnostic tool is the ultrasound. So in the presence of ultrasound, not logic to use the von Rosen view.
The second question is, how often do you use arthrogram in your work?
Arthrogram, I use it if I found there is something there. I mean, there is unstable head, or there is something inside the head that make the reduction not concentric, so that I need arthrogram to confirm my diagnosis. Otherwise, if the close reduction was stable and I feel the hip is concentric, so no need to do arthrogram. So I mean, arthrogram is not a routine in a treatment for close reduction.
Are you speaking about per-operative?
Yes, per-operative.
You speak about per-operative. Okay.
So if I decided try to do a close reduction, I do an adductor tenotomy with a close reduction and check for stability. So if the hip stable at that time, that's okay. No need to do arthrogram. But if I feel the hip, I am query whether it is stable or not, at this time I can use arthrogram.
Thank you very much. Thank you very much, Ali. Dr. Isam, Isam, are you ready now? Can you unmute yourself, please? Unmute yourself, please. Your mic is closed. Your mic is closed. Dr. Isam, unmute yourself, please. Yes. Yeah. No. Back. Yes. No. It's difficult with Isam. Isam, yes, it is okay now. No. I'm sorry. Dr. Mohsen, what do you think? Why is that?
I think it is technical problem at Dr. Asam's side, maybe in his laptop. I don't know.
I will move to Dr. Borair, please.
Yes, sir.
Dr. Borair, I must congratulate you on your this screening program in Karbala. And can I ask that, is it now an active, obligatory steps or program you are doing on every childbirth?
No, sir. Actually, we are not happy too much because they are speaking about the problems we face, and these cannot be solved till now. Many problems cannot be solved regarding the number of radiologists, and this is the main issue. That's why when we try to do it in every healthcare center, it is difficult because there is not enough radiologists. Till now, we applied only in 5 centers only, and now we are shifting the idea to do it into just to promote them in the hospitals after birth, and we make a paper for them to give in to the parents that you should go to nearest healthcare center in your home after 2 months to check by ultrasound. This may be beneficial, and we don't know now.
Yes, there's a question here. Do you think that orthopods or pediatric surgeon must or can learn to do this technique and use the ultrasound probe as a stethoscope for the hips to examine?
Yes, it is mentioned maybe in the near future.
Do you think they can be trained as part of their training program? You think so? Yes. Because as I understood, in some places around the world, surgeons are doing the ultrasound themselves.
Yes, even Mr. Graf, he is orthopedic surgeon.
Very much. Yes. Did you feel that the incidence of your operations has increased after you started this screening?
Yes, sir, sure. We have now list, me and Dr. Hassan, about list of patients because many of those patients coming. And I think the main point here is the education. The screening program may fail at any time, but the education is the most important because the family, when they get educated, one will educate each other about please go to check the hip of your baby. They will told one another to another. And this is the main point I think we will get. And we will discover unfortunately many cases. We discovered unfortunately many cases.
Yes. If it is free and available at the health family centers, I don't think family will object to that. Whenever they reach the center for any other reason, they can catch them to do this 10 minutes maybe examination.
Yes. Really, the families are very, very grateful to us. But the problem is that in the radiologists available or not, because some centers
Yes. Thank you very much. Thank you very much. Back to you, Isam.
Hello, Dr. Mohammed, تسمعني ولا?
Yes, I hear you.
Okay, كل زين.
Now, the question is, one of the colleagues asked.
I hear the question, but we did an X-ray for the patient with CT with MRI. If there is a possibility of foreign body, it will show in the CT and in the MRI.
Of course.
Okay. In addition, I open him without any sign of any foreign body or scar tissue inside. Okay.
So what was the final answer? What was the reason? What is your opinion now?
I don't know. It's actually the picture goes with severe disease, but for a long time, 1.5 years, it's unusual presentation.
Okay. Thank you very much. Thank you, Isam. Thank you very much.
Okay.
أستاذ محمد ممكن؟
Yes, Dr. Wali.
Sorry. Thank you, Ustad Muhammad. Just a comment for my dear colleague, Dr. Borair, for the screening. Yeah,
Sure.
this is a big task, and really I appreciate they great effort, and they are maybe the pioneer in this program. So I want to thank him very, very much. I think we have two main problems: the education, as he said, Dr. Borair, and the technical point. I think we can train some assistant, not necessarily the gynecologist alone. Any nurse in the theater, in the obstetric theater, can be trained to discover the sorting of these units, and they refer them, of course. The other thing we suggested for the MOH that the birth certificate will not be given unless signed by somebody who is authorized that this baby is being screened and he is negative or positive. Thank you.
Dr. Muhammad, please.
Well, you know that actually you were the pioneer or the first person who tried to do this through the Ministry of Health, but it was difficult, many difficulties, and the environment in our country is slightly does not encourage starting such a big program like this. And we hope one day your dream will be fulfilled, and maybe you start in Karbala and it will expand all over the country. Thank you very much. We always remember.
Dr. Muhammad, I think,
yes.
Dr. Muhammad.
Yes, please.
I think for Isam, did he take a bone biopsy?
No, because I saw the calcaneum was normal in exploration.
No, Isam, you cannot say normal from a macroscopical appearance. As far as the pain persists, not responding to analgesia, not responding to conservative treatment, I think personally you have to take a biopsy from the bone. This is my feeling.
Okay, thank you very much. Thank you.
Hello, Muhammad. Muhammad. Hello.
Hello. Hello.
You hear me, Muhammad?
Yes, I hear you, Dr. Hassan, Professor Hassan Kadhim.
Hello. Actually, I'm asking.
I hear you. Yes.
Hello. I asking Scott.
Yes. Go ahead.
Does he classify the club food before he start his programming for the treatment as it is a difficult club food, as it is a simple club food, and so we program the treatment? Because I remember, Muhammad, classification of Mr. Atimbala in 1966. To start with, he classified the food. This is a difficult one. This is a simple one. Whatever you do for the difficult one, it is actually reliable and for recurrence. And whatever you do, simple thing for the simple food, simple type, and he knows, and I know as well, how we classify them to start with. Thank you.
Yeah, I was just actually typing the answer there. I don't use the classification systems. You know, I've heard the Ellen DeMiglio's classification and Shafiq Pirani's classification, but I think a lot of that has been changed with the Ponseti method. The vast majority of the feet respond nicely, and I found that I can't tell until I put 1 or 2 casts on. I'll put 1 or 2 casts on, and after I take the second cast off, sometimes the foot just looks like, wow, look how great that is. And sometimes I think I'm going to make nice progress, and the foot looks back at me and laughs. So the only distinction that I know that Matt Dobbs uses is that of an atypical club foot. If there's a crease on the bottom of the foot, a deep crease in the plantar, and the great toe is hiked up, hyperextended, that complex atypical clubfoot, there's a slightly different casting maneuver. You basically just try to cast out the cavus. But once you do that, then the Ponseti method works. So I haven't used a classification. I didn't find them very reproducible for me, and I think Ponseti has made that less critical.
Okay, thank you.
Thank you very much. Dr. Ali Bakr Hali, do you want to add anything as far as you are with us?
I think I have a question to Osam, if it is possible.
Yes, sir.
I mean, I gathered the situation of this case, altogether, it was not very, very painful because he was walking, the patient, on his foot.
Yes.
Isn't it? And because of his walking, but there is only swelling, I think we have to put the elements of neuropathic condition with this foot. Otherwise, we can go anywhere else. Thank you.
Thank you very much. Thank you.
Thank you, sir. Dr. Ali Bakr, do you want to comment?
Thank you.
Yes, sir.
Thank you.
Yes, sir. Thank you.
With us.
Thank you.
Yes, sir. Thank you so much. It was a very nice presentations, very great discussions. I encourage Dr. Borer to continue on the screening program. I think he will get more difficulties in the screening program, but hopefully he will, he will start it and he will be successful. Thank you, sir.
Very much. Thank you.
Will be successful one day.
Excuse me, I remember a case 10 years ago.
So anybody has anything to add before we close?
Dr. Muhammad, I think Dr. Walid remember a case 10 years ago. We did open reduction for DDH for that child, 2 years old, and his mother and his father, both of them are doctors. And I think Dr. Walid maybe remember that case or not. So it is a problem of education, even among the doctors which are not orthopedic, maybe.
Your mic, Walid. Walid, your mic. Your mic, please.
Yes, sorry. I have a pediatrician with his wife is an anesthetist. Both of them are doctors, specialists. Brought their daughter about 4 years of age with bilateral DDH.
Yes. Well, this is a specialty actually, pediatrics and DDH. Not every doctor is aware about the problem. Yes, of course.
Yeah.
David, do you want to comment any before we close?
دكتور علي أقدر أحكي وياه علي العيدان. Can I talk with Dr. Ali?
Why not? Is he still with us? Ali, Dr. Ali Al-Idan. Yes, he is here.
Okay.
Yes.
Dr. Walid has some question to you, or want to talk to you.
Thank you, Dr. Ali, for your nice presentation. I quite agree with most of your thoughts and opinions and the practice. And I hope you will be successful. I wish you the best. I think for the unit, X-ray and the screening cannot be requested unless the unit is about at least 5 months of age.
Yes.
Yeah, usually it was at 6 months. And now they agree to have it at 5 months of 5 months of age. The erythrogram, I think, is caught, and maybe David, they're a bit away from the erythrogram now because of high exposure to X-ray. The other thing, the revision is a very, very difficult task. I quite agree with you. You might need only to try it once, never twice. Leave them better.
For me, as I told you, I always ask about the first surgeon and depend on that. If the first surgeon was expert, I not do any revision after that because I understand that he did the best.
Yeah,
but if the first surgeon not expert, I know them. So most of them I And most of that time, I try to do a revision because I found that most of them, they did a halfway surgery, as I told you.
Sorry, the revision, this is in the text. This is in the text. You try once, never try twice revision.
Yes,
The result, whatever you do, it will be very, very bad. This is another thing. Yeah. The other thing, sorry, I saw you do transfixing wire.
This was before, not now.
Before.
No, this is a failure before. And so, no, you mean those transfixing the hip?
Yeah, during surgery.
No, this is not mine. This is some cases that they did a surgery outside. I presented these cases at when the slide of if you don't do good, don't do harm.
Yeah, my message now, you can use the transfixing wire.
No,
in
it's
special
not
case.
preferable.
Sorry. This is my opinion. If you you
better
feel
to avoid.
Better to avoid for chondrolysis, for stiffness, I quite agree. But there are some cases, I think you are not happy, you are obliged, you can do it, permitted to put it for 1 month and you remove it through the spica, 3 weeks or 1 month.
I do it after revision only.
Maybe after revision.
Yes.
The other important thing, as you mentioned, always remember neuromuscular disorders. It is one of the manifestation of a neuromuscular. Thank you. Thank you.
Thank you so much, Dr. Wadi.
Thank you.
Thank you very much. Dr. David, you want to comment as far as you are with us? Dr. David?
I guess I enjoyed all the presentations, and I think screening is certainly a very effective tool based on the statistics that you saw. We see very few delayed presentation in DDH, and it's getting to the point in our country where your average resident or fellow does not have sufficient training to do open DDH surgery in older patients. So public health has been successful. But with regard to the other questions that have come up all along, in general, our training is to avoid fixation with a K-wire. And if we do so, then trying to avoid putting it intra-articular, trying to make it extra-articular and to leave it in for a short period of time, as you've mentioned. And as far as the pelvic osteotomy goes, this is an area of debate. And some of the doctors are discussing potentially using the arthrogram to choose between a Salter and the Degas or volume reducing type of an osteotomy. And for example, if there's dye pooling superiorly, maybe that suggests that one can do the Degas. Others have talked about resisting or a problem with the Degas being that you can achieve some compression on the femoral head as you bend the acetabulum down. So I think amongst those that do a lot of these surgeries, and Scott, of course, I welcome his comments. I think there's still debate between the Salter and the volume reducing pelvic osteotomies. But anyhow, I enjoyed all the discussion and thank you for letting me participate.
Thank you very much. We are happy to hear that from
Muhammad.
Yes, Dr. Hassan. Yes, Professor Hassan.
Actually, I've got only one message regarding putting the transfixing wire in whatsoever. I never actually happy anytime when I open reduction. You should be happy on the table and with the patient anesthetized that your reduction is completely easy. Head going to the acetabulum. It is easy to go full range of movement, even not necessarily full range of movement, but within the limit of abduction, internal, external rotation. And at that time, you feel that your hip is stable whenever you have the reduction. But in any time when you feel unhappy that the head is going inside the acetabulum by difficulty, or there is no roofing for the head, or there is still anteversion, these things which were not correctable or not be corrected by putting the wire, but just to keep you happy that perhaps when I do the gypsum or I do the casting, perhaps the head will go out. And even if you leave the patient moving after the head is still here because you are doing good capsulorrhaphy, you are doing good release, you are doing good reduction, you are doing good cover, you are doing good mechanical position of the hip. So at the time you feel happy, perhaps, as Ali said, perhaps when the surgeon is starting with or he's not happy, he can do it, but not transfixing. He can put the wire above the head, above the neck, just to keep it with the level of the pelvis. Thank you very much.
Thank you very much, Professor. Thank you very much.
Hello.
Now,
we'll put not in the hip joint, in the ilium. From
That's
the
right.
greater trochanter to the ilium.
That's right. Thank you.
Along the neck. Yes.
Yes.
So I think Mohsen will be closing now. Dr. Mohsen.
Yes, I'd like to thank all of our respected speakers and all of our attendees for their time and for their contribution to make this webinar successful. Also, I'd like to remind the respected attendees that tomorrow on the same time we have the second session of this webinar starting 9 o'clock in the evening. So,
inshallah.
Thank you again and see you tomorrow, inshallah.
Thank you all and we'll see you tomorrow.
Thank you all.
Good night. تصبحون على خير.
Good night.
Thank you.
تصبحون على خير.
See you.
Good night. See you tomorrow. Bye.
Hello.
Thank you all.
Bye.